So as Sarah said, I'm used to be in the School of Women's and Infants' Health, and now I'm in the Division of Obstetrics and Gynecology, or DOG, in the dog house, in the HMS. And if you actually Google, just out of interest, if you Google DOG HMS, this is what you get. This is very cute image. So John, that's the new mascot for the division. And as John said, I'm going to finish the talk. We started with preterm birth, so I'm going to finish with preterm birth. And I'm going to talk quite a little bit about the background and what we know. We spend sort of 25 years kind of figuring out how infection and inflammation drives preterm birth. And then I'm going to talk about some exciting results we've got about how we can predict who's going to deliver preterm because of infection and therefore do something about it. And then spend the rest of the talk talking about the anti-inflammatory approaches that we've been working on. And I'm going to skip through a few slides because I told I haven't got 25 minutes, I've only got 20 minutes, so I'm going to go a bit fast. This is a gestational age distribution of births across Australia, so you can see the definition of preterm birth before 37 weeks, and we're about 8.5%, and that rate's been pretty stable for a long time, actually going up due to the late preterm births that the Preterm Birth Prevention Initiative has actually managed to lower. Preterm birth is actually a syndrome. It's caused by has multiple causes, many of which are listed here. And this is a diagram by Roberto Romero, who is the guru in the field. Roberto is a fantastic fellow. He publishes 100 papers a year on perinatal research. So he's an amazing guy. And 5 of those papers were co-authored with me. And he actually read the papers and he worked on them. So he's quite remarkable. I'm going to talk about infection, as I alluded at the start of the talk, but actually many of those causes on that slide there are actually involve inflammation. And that last one, the unknown box on the right, that really should be non-infectious inflammation. And inflammation underpins, sorry? Yeah, they're all inflammation. Yeah, inflammation underpins many, if not all of those causes. Okay, so just to give you sort of a brief overview of what we know about how infection causes preterm birth. So firstly, we get bacteria ascending through the cervix, penetrates the fetal membranes and starts to colonize the amniotic fluid, and then will actually reinfect the membranes from the inside out and trigger... Oh, so it looks like some of the animations haven't worked. Okay, that triggers a response, an immunological response that results in the production of prostaglandins and other immunological factors that you can measure in preterm birth. There are inflammatory cells, and the glucose concentration of the amniotic fluid actually drops because of all the infection. There's enhanced expression of inflammatory genes in the fetal membranes. There's collagenlysis, so that's degradation of the fetal membranes that causes the membranes to rupture prematurely. And there's neutrophils and other immunological cells coming into the fetal membranes to try and kill off the infection. And when the placenta's delivered, you can do histology, and the histologist will see that as something called chorioamnitis. So often chorioamnitis is diagnosed after delivery and is thought to basically be a correlate of an infective cause for preterm birth. All those things can result in fetal sepsis and an inflammatory response in the fetus, which is very damaging and associated with a lot of morbidity and mortality, and of course increased risk of preterm birth. And there's some of the neonatal consequences of being born preterm. What we do know is that it's very gestational age dependent. And so the earlier the baby is born, the more likely it is to be born due to an infection. But we also know, and this is something that's been, when I first started in this field, it was sort of anecdotal, but we know very clearly now that also the rate of inflammation without infection is also very common in the earlier preterm births, but is a significant cause throughout all deliveries. So you can see this is again another piece of data from Roberto Romero. And you can see in the earlier gestations here, almost all of them have either infection or inflammation, and that's the infected group, and that's the inflammation without infection group. And as you get later in the gestational age increases, the rates decrease. So it's particularly important in terms of the etiology of the earliest babies, and of course they're the ones that are most sick, the most likely to die, to have serious morbidity that lasts a lifetime. And that's just illustrated in the next slide here, which shows, again, gestational age on the bottom, and the rate of intrauterine inflammation, total, and the proportion that's caused by infection. And if you look at the death and major disability rate. It's very, very high for the earliest babies and decreases precipitously towards with gestational age after about 32 weeks. And that's the proportion of all preterm births. So most babies are born late preterm and have low morbidity and mortality. The very sickest babies are a very small proportion, maybe 1% of all deliveries. It's very important to realise that this is a continuum. So you don't get suddenly an infection and delivery within the space of a few days. There's a wide variety of sort of scenarios depending on the nature of the organism, how it gets to be where it is, the immunological response of the mother, the placenta, and the baby, and other factors that modulate the progression of the syndrome, if you like. And that's shown on this slide here. And the sickest babies, the ones that are diagnosed with intrauterine infection and have fetal sepsis, are shown here at the sort of the end, the right-hand side of the time course. But you get chorioamnitis and signs of inflammation even quite early on. So depending on when the mother turns up in preterm labour at the clinic, depending on what you measure and how you measure, you're going to get maybe part of the solution, part of the answer, part of the diagnosis or not, depending on whether you can measure inflammation, whether the bacteria has reached the amniotic fluid or not. And this is all very hard to diagnose in real time when a woman presents with preterm labour in a hospital. And this is important because the ability to diagnose infection and diagnose inflammation, therefore, is important information in prescribing the correct treatment and deciding whether you need to give antibiotics or need to give an anti-inflammatory or you need to give both. And I would say, because it's such an imprecise act in terms of the diagnosis, almost always in these scenarios we need to assume there's an infection, even the infection hasn't reached the amniotic fluid yet, and we also need to assume that there's inflammation. So both need to be targeted at the same time with an effective therapy. Right, so we know quite a lot about the bacteria that cause intrauterine inflammation. There's a lot of them. Some of them are associated with a dysbiotic syndrome called bacterial vaginosis, which a lot of people have written about and a lot of people have used as a sort of marker of risk of preterm birth. But actually the most common organism that causes preterm birth is in fact a thing called urea plasma. And John's group has worked a lot in urea plasma in the sheep, and a lot of other people have worked and shown very nicely that it's a causal relationship. So urea plasma infection in the amniotic cavity provokes a very robust inflammatory response, and that's associated with preterm birth, increased rates of morbidity and mortality of the neonate, and is definitely a significant problem. However, many women have, and men in fact, have ureaplasma in the ureterogenital tract, and most women who have ureaplasma do not deliver preterm. These are the data here we published a little while ago from a cohort in King Eddie's Hospital where we work, and hopefully you can see on the writing might be a little bit small, but all the ureaplasma rates here. This is in the preterm group on the left, and on the right is the term group, and you can see that 85% of the preterm group and 45% of the term group had ureaplasma present. It's called species here because there's two species of ureaplasma, one called parvum and one called urealyticum. And in fact, we showed that in fact it's the U. parvum that's much more likely to be associated with preterm birth than the urealyticum. And in fact, number 6 here, Serovar 6, is very significantly increased in the preterm birth cohort compared to the term cohort. Now this is important because up until very recently no one's been able to measure the serovars. There's 14 of them in case you're interested, and most of the old studies just talk about ureaplasma as if it was one species and one serovar. So really they've missed out this sort of very important mechanistic and correlative information. And we are really the first people to have sort of nailed this and got some data on it. So our ultimate aim is to identify women who are at risk of microbial-driven preterm birth so we can give them the appropriate antibiotics and do this diagnostic in mid-pregnancy before the bacteria have had a chance to get through the cervix and colonize the amniotic fluid and start growing and start the inflammatory response, which we know causes damage to the fetus, particularly if it's long-term. So we aim to do this before 20 weeks because some antibiotic trials have shown that if you give the antibiotics to a high-risk group before 20 weeks, you can actually lower the rate of preterm birth. So how do you predict? How do you identify women who are at risk? One of the best studies is this study here from a guy called Gilbert Donders for Belgium. And he did a large study looking at risk factors, and particularly bacterial vaginosis, the presence of a thing called Mycoplasma hominis or Candida. And as you can see from the data there, the bacterial vaginosis, the odds ratio was about 2.5, and another kind of similar dysbiotic syndrome is called aerobic vaginitis, and that was about 3. So the risk, in terms of risk profile, it's not particularly useful, and also because most of the organisms that are present in bacterial vaginosis aren't actually the causative organisms that cause preterm birth. Importantly, he didn't look at Urea plasma parvum or at serovars. There's a program, I'm just going to skip that slide, there's a program in Austria where they actually did a similar screening program before 20 weeks and then treated, and as you can see there in the intervention group, the orange bars, they significantly lowered the rate of preterm birth in women either with bacterial vaginosis or Candida. That was a randomized controlled trial. Then they rolled this out as a program and got even more significant results. So basically this shows that if you screen and identify risk factors and treat with antibiotics or antimicrobials, you can actually have a very significant impact on the rate of preterm birth. But the problem here is that they're using bacterial vaginosis, which is a very poor marker, and they're not really capturing the urea plasma data, which are those are the real women at risk. So we have conducted a trial, an HMRC study over the last couple of years, recruiting 1,000 women at low risk and then doing vaginal microbial screening before 20 weeks. And these are some of the data from our data so far. And you can see that this is a molecular basis of a molecular diagnosis of bacterial vaginosis. There's 9.1% 9.1% were positive, and 59 delivered preterm, and only 8 women with the bacterial vaginosis were predicted by. Only 8 women who delivered preterm were predicted by being positive for bacterial vaginosis. So we have developed a test based on Urea plasma serovars and 2 other bacteria, and I can't tell you what it is because it's being patented, but I can tell you what the results are. And you can see here that 157, we call it the glue test, so 157 patients out of 1,000 would be positive, and 21 of the 69 women who deliver preterm would be positive, which is pretty good. But if you look at the gestational age of the women, you can see, and this is bacterial vaginosis compared with the glue test here. So the bacterial vaginosis detected these preterm births here, and then none before 35 weeks. Whereas the glue test had double the detection rate of preterm birth, but detected nearly half of the women who delivered preterm before 35 weeks. And if you remember, I told you that most of the women who have an infective cause of their delivery will deliver early. So you would expect the test to be able to predict the early preterm births and not so much the late preterm births. So we're very excited about these results, and we have a clinical trial designed, hopefully under consideration by the NHMRC, to prove that if you treat these women based on the test, you will lower the preterm birth rate. And then we can roll it out and sell the test. 350 million people deliver every year. Even if we only sell it to 10% of the women and I only get $1, that's $35 million a year, so I'll be happy. Yeah, you dream, yeah. Okay, moving on to the anti-inflammatory agents. Right, so inflammation. Pregnancy is a state of heightened inflammation, and that inflammation is suppressed by the effects of progesterone. And I like to think of it as a sort of balance, this pivotal balance here. So progesterone is keeping the myometrium quiescent and helping to counteract any effects of progesterone. And as pregnancy progresses, things happen. You get increased oxidative stress, the placenta starts to age, it produces inflammatory mediators into the maternal bloodstream, the fetal organs start to mature, particularly the substances produced in the lungs. All these things start to provoke an inflammatory response, and as the gestational age slider here sort of moves to the right, then the inflammation outweighs the effects of progesterone, and eventually you get a precipitously rise in the last few weeks, causing the inflammatory response that you need to deliver to cause delivery and labour and delivery. So how do we exploit this in terms of prevention and treatment of inflammation for getting better clinical outcomes? So firstly, we've got to decide what the goal is. Is it delaying delivery or improving neonatal health? How does the presence or absence of intrauterine infection impact upon inflammatory treatment strategies? And as I said before, I think you always really have to assume that there's a silent infection, and so you've got to give antibiotics at the same time. Is the therapy aimed at preventing chronic inflammation or treating women in preterm labour? In other words, is this a prophylactic treatment that you start early in pregnancy, or are you just treating an acute situation where someone's in preterm labour, probably with massive inflammation? Who do we treat and when do we treat? How do we diagnose? How do we figure out who really has at risk of high levels of inflammation and adverse outcomes? What drugs do we have available? How safe are they? What are the potential risks, not only to the mother but to the fetus? And importantly, do our experimental models mimic the most clinically relevant scenarios? So to answer some of those questions, so the primary goal first is to improve neonatal long-term outcome. We want to delay labour, that's true, but not at the consequence of neonatal health. For prevention, maternal infection inflammation is the therapeutic target. For treatment, in other words, for symptomatic women, therapy should mitigate the effects of inflammation and/or infection on the fetus. As I said before, preventing preterm birth shouldn't put the fetus at risk. And as I also said before, absence of a detectable intra-amniotic infection or inflammation doesn't rule out chorionitis, because it's basically impossible to tell until the baby's delivered. And as a consequence, I think we need to give dual antibiotic anti-inflammatory therapy for optimal benefits. So we know quite a lot about what drives inflammation in the absence of infection, and some of the triggers and the molecular drivers are on this slide here. There's intracellular and extracellular, and I'm not going to go through them for time, and also because it's more of a general audience. But we know a lot about these. We can measure some of them, but lots we can't measure. A lot of them are intracellular or intra-amniotic, so it's useful information. But what is particularly useful in terms of exploiting this information is the endpoint. Inflammatory signaling is driven by these sensing molecules called toll-like receptors in almost all cases. So if we can look at toll-like receptors as the endpoint target, we can basically cover all of those multiple molecular mechanisms and prevent inflammation-driven preterm birth in many, many cases. Right, so protection and prevention in at-risk asymptomatic women. So these will be women perhaps who have a high CRP or a high IL-6 or something in their blood, have a history of an inflammatory conditions such as obesity or diabetes, or maybe have an infection such as a flu infection, some kind of infectious disease. So whatever we give would have to be given chronic, probably over a long period of time, maybe start early in pregnancy. Obviously, in those conditions, then maternal and fetal safety would be paramount, because these are low-risk women, so the tolerance for adverse effects is very low. And there's been a lot of interest in a lot of different things, and dietary supplements have been looked at. There's some quite interesting data, epidemiological data, showing that people who have certain diets in pregnancy have much lower rates of preterm birth than others. I think that's, it's epidemiological data, and sorry, Michael, but, you can interpret this a long way. There's a lot of confounders, but it is interesting. And in the grey on the slide there are some of the substances that have been sort of raised and looked at. And we're actually looking at this new nano-curcumin formulation. So you might know about curcumin, kind of a wonder drug, but it's very poorly absorbed and doesn't really do anything. But there's a formulation that greatly increases its oral bioavailability and totally transforms what it can do in terms of therapeutic effect. You've got to look at bioavailability, as I said, stability and quality. Does it cross the placenta? You wouldn't want it to cross the placenta in these conditions. How does it affect maternal immunity? Because you don't want to make the mother more susceptible to a disease, because you suppress some kind of immune response. And if you take it, does it actually delay term labour? On the other situation is for those who are symptomatic, so they probably have a raging infection and or inflammation and have turned up in the preterm labour clinic. There's again a lot of drugs that have been looked at. We've looked at the second of those, the CSAIDs, the cytokine suppressive anti-inflammatory drugs. TLR4 antagonists, which I'm going to talk about in a minute, a whole lot of other things. So these would have to be very, very powerful drugs. You would administer them quite acutely in a short space of time for someone who's in preterm labour to try and mitigate the effects of the inflammation on the fetus, particularly the fetal brain. You need to spare the fetal brain as much as possible because it's very susceptible to damaging effects of inflammation. So again, it have to be effective, safe. You'd want placental transfer if you gave it to the mother. Would have to preserve maternal immunity and again not affect preterm term labour. So this is only one mechanistic slide, so I'm just going to go through it very briefly. So we have the pattern sensors here responding to various bacterial ligands on the top, going through a common pathway, a shared pathway involving this enzyme called TAC1, and then bifurcating to the MAP kinase and the NF-kappa B pathway. These regulate the transcription of all the inflammatory genes we know about, causing myometrial contraction, ripening, and membrane rupture and delivery. So there's a number of different approaches. You can target each of these little red dots here as a drug kind of target with drugs that have been shown to do various things. The first one I'm going to talk about briefly is this drug called oxazionol, which we've been working on. We've shown in the sheep that it blocks the inflammatory response in utero. In human placentas delivered preterm, it blocks the inflammatory response. Its attraction is that it acts on both of these pathways here, but won't affect them through their constitutive activity. And NF-kappa B and MAP kinase have lots of important roles in the cell. So it stops them being activated in response to a whole lot of inflammatory mediators, not just from bacteria, but from other things as well. So it should be pretty effective in many, many circumstances. We've got some studies underway in rats and a collaborative project with Sarah looking at this drug in her mouse model. The next drug I want to talk about is, in fact, Sarah's drug. Sorry, Sarah, I'm going to present some of your data. Hope that's okay. This is a drug that targets the receptor for LPS, TLR4, and this is a drug called plus naloxone. Plus naloxone, you've probably heard of naloxone. It's the drug that you give opioid addicts to block the effects of opioids. Well, this is an isoform of naloxone that doesn't act as an opioid, but exerts very potent anti-inflammatory effects. And Sarah published this very nice paper showing in mice given bacteria, a bit grey, hard to see from here, but this is the stimulated on the third bar, and then on the right-hand side is the suppressed with naloxone. You can see a whole lot of cytokines and genes being affected, and perhaps more impressive in the LPS model, increase in pup survival. And if you look here, these are the LPS treated pups here. You can see greatly reduced growth, completely protected by the naloxone, plus a whole lot of other effects in preterm birth rates. So very impressive and a very exciting drug, and we're going to compare this with our TAC1 inhibitor to see whether one or the other is better in different circumstances, what dose, what kind of timing needs to be considered. The second drug I'd like to talk about is quite a new approach. This is an allosteric receptor antagonist called Revita. And you might be confused to thinking I'm talking about Revita. Please, it's not the same thing. Don't go home and tell Jeff Keelan said you can take Revita to stop preterm birth. It's a peptide, nothing to do with a biscuit, and it's actually named after the amino acid sequence, if you're familiar with that. So this was developed in Canada a few years ago by Sylvain Shemtob and his team, and they published this very nice paper which I reviewed and said, hey, this is fantastic. And so I started a collaboration with them. And this works by stopping the binding of the accessory protein to the receptor for the IL-1 receptor. Interleukin-1 is one of the most powerful drivers of inflammation in the body. It's very important in the neonatal brain. It's elevated in cord blood from infected neonates and is a very good target. In fact, there's a drug that works on it. It's called Kineret. It's available commercially. It's very expensive. So the peptide, if you can see here where it says 101.1, the peptide actually binds here and blocks the binding of the two components of the receptor, so it blocks the receptor activity. I think I'll skip that. And it's just a brief summary of all the things it does. It really is amazingly effective in the mouse model. The right relay is in the third bar. Some of these are stimulated with IL-1, some with LPS. Some of them have Kineret and you can see that the Revita is much more effective than Kineret, and right across the board it's having profoundly protective anti-inflammatory effects. So again, this is another project that we've got in with the NHMRC. We're going to test this in human cells and human tissues, look at its transfer across the placenta, do more studies in the mouse, more studies in the spiny mouse with Haley Dickinson, and importantly in the sheep, directly intraamniotically into the sheep to look at long-term, short-term and long-term outcomes in the fetal sheep model from Perth. So, summary. Firstly, prevention is better than cure. If you can prevent the inflammation and the infection, that's best. The antibiotics will work if we can decide who to give them to. So hopefully we've made a big advance there. You've got to have different therapeutic strategies for prevention and treatment under different circumstances. The low-risk women early in pregnancy or the women at high risk who's turned up with preterm birth. Different drugs, different timing, different safety issues. We've made significant progress, I think, in all these scenarios, and some exciting things to come. But I just raise a flag of caution. History is littered with great things that worked in animal models that when translated into the human scenario and in clinical trials just falls down, and the heterogeneity and all the confounders completely destroy everything. So although I'm a permanent optimist and I think we've got some great ideas to follow up, success is not guaranteed, and don't put your money on it. Yeah. Thank you very much.